Good afternoon, everyone, and welcome to our meeting. I'm Robert Peat, Chair of the IJB. You're all very welcome. I think, have we anyone who's here for the first time? I think everyone has perhaps been before. Colin Payton, you're very welcome, Colin. You're here for one of the later agenda items, the report from the Alcohol and Drug Partnership. And welcome, everyone. We have a fairly full agenda. Just remember, it's a really lovely day outside. Okay. Maybe it was just me that got that point, but never mind. Okay. Do we have any apologies?
Chair, we have apologies today from Lorna Stewart, who I believe is just running late, also from Pat Kilpatrick and from Linda Lenny as well.
Thanks very much, Scott. And are there any declarations of interest? No. Okay. Shall we move on to agenda item 3, which is the minute of our joint board meeting of the 1st of May. You have a copy of the minutes with your papers. If I could go through, first of all, if there are any points of accuracy on page 1, 2. Sorry, it's page 5 of the papers, page 6, 7, 8, 9. Happy with the accuracy of the minute? Thank you. And we have the action points update. I think if you've had an opportunity to look at the action points, they're either on the agenda today or we have dates for those action points to be considered at future meetings. If there's anything anyone would like to pick up on from the action points update. Are you happy with what's described in the paper? Okay. Are there any other matters arising from the previous minute? Gordon?
Yes, thanks, Chair. Just at item 6, board membership update, to advise that we have progressed the discussions about the process of electing carer representatives onto the IJB and have convened a meeting with the public partners to discuss that. We have a plan that will deliver on that election and secure us new or returning candidates later in the year. So as the last IJB agreed, the existing carer public partners continue to be members. The date that we've identified to bring public partners in to have those discussions is unsuitable for one or two, so we're going to have to reconvene that, and it's really important that we get that meeting involving all 4 public partners, particularly because we're going to be spending a bit of time looking at how we can more effectively support public partners in their role as IJB members. We've been alerted to the need to do so, particularly thinking about new public partners seeking to be elected. We'll have to have a very good understanding of the expectations, responsibilities and the role. So we're looking at how we can build that support as requested by the last IJB.
I'll get used to this one day. Item 6, the membership update. Be aware that Jim Fowles had retired and we're proposing that Sarah Dickey from NHS Tayside be appointed as a non-voting member of the IJB. Are you happy to approve that appointment? Yes? Okay, thank you. Which takes us on to the finance and governance section. I wonder if I could ask for the various parts of this to be reordered. So we'll deal, if you're happy to deal with item 7.1 first of all, then 7.2, then we'll move to 7.5, and then 7.4, and then 7.3. So we'll do 7.1, 7.2, 7.5, 7.4, and 7.3. I just felt that that would flow better in terms of going through the finance and governance section of the agenda. So are you happy to do that? Takes us to item 7.1, which is the financial position in relation to 2018-19. And you have the paper which sets out obviously where we got to at the end of the last financial year, obviously as a result of a considerable amount of work from a range of people, particularly officers who were involved, obviously the members of the board who are also part of discussions with regard to the financial situation and obviously the recovery programme that was put in place. Jen, would you like to give us a summary of the report, the key points you'd like to highlight?
Thank you, Chair. As the Chair has said, overall we are reporting an overspend of 1.1 million for 2018-19. Breaking that down into its constituent parts, for core services we actually achieved a small underspend, a major achievement given the unanticipated significant social care pressures that emerged during the financial year. The implementation of the financial recovery plan has been absolutely key in offsetting those pressures, along with a number of unanticipated benefits, and just generally the actions of all officers to do everything they could to bring the position as close to break even as possible. Where that leaves us in terms of the year-end outturn then is that the key drivers of the overspend have been the prescribing position and the inpatient mental health position. Both of these positions reflecting the formal gap in the financial plan at the start of the year as approved by the IGB, so in many ways not a surprise, although every effort has been taken throughout the financial year to offset them. For prescribing, it's worth noting that whilst we have overspent significantly by just over £800,000, that needs to be seen in the context of the outturn for the financial year 2016-17, which was an overspend of £2 million, and in 17-18, which was an overspend of £1.7 million. So whilst we have overspent on prescribing, we can see a downward trajectory and a significant improvement in the financial position. For inpatient mental health, the outturn gap was in line with expectation, which was in many ways a major achievement because a number of the transformation proposals that formed part of the financial plan at the beginning of the year were not able to be implemented, and therefore the savings weren't delivered, yet we have still managed to deliver against the financial plan expectation. So in line with the integration scheme, the £1.1 million overspend was met through the allocation of additional budget by Perth and Kinross Council and by NHS Tayside, allowing the IGB to break even. And that's what is reported throughout the annual accounts. What you'll also find when we come to the annual accounts, however, is that we have 2.47 million of earmarked reserves, which we will carry forward for future years to meet spending commitments in relation to Scottish Government priorities around primary care, mental health and drug and alcohol services. Happy to take any questions.
Thank you, Jane. Are there any questions from any members or any comments in regard to this paper? Eric.
Thank you, Chair. I just wanted to pick up on the comment made at 3.1 in relation to NHS directed services and the reference to significant slippage in recruitment to key posts, which is obviously a recurring theme in a number of areas, not least in inpatient mental health also. Are we able to identify, I mean, obviously the financial position is improved, but still very difficult. How much of the financial pressure across the piece is related to slippage in recruitment and difficulties in staff retention?
I'm not able to give a specific figure. That's something we can certainly provide. But what I would say is that the vacancies that we've referred to were not in any way specifically held for the purpose of offsetting the financial position. They related to a delay in just the challenges in recruiting to a number of posts, particularly relating to elderly services, where we had investment funding set aside to improve services, and the time taken to actually appoint to these posts has been longer than anticipated.
Any other comments or questions? Thank you, Jane. You're happy to note the recommendations within the report? Thank you. Which moves us on to item 7.2, which is the paper on GP prescribing and the other hosted services, the budgets for 2019-20 to 21-22. It's a report from Chief Financial Officer, but I wonder if both Callum, as Chair of the BRG, and Jen, if you'd like to comment in relation to the report.
Okay, just to remind members that at the meeting in March, the IGB meeting in March, you approved the 3-year financial plan for core health and social care services and noted a gap of 2.842 million and asked for further plans to be brought forward. I just wanted to take the opportunity today, before moving on to the prescribing and other hosted services plan, to note that a financial recovery plan for 2019-20 is now being developed, and it's anticipated that following discussion with NHS Tayside and Perth and Kinross Council colleagues, this will be, and then with IGB members through the BRG process, that this will be brought forward to the IGB in September for approval. What this paper today does is it builds on that core services plan, and it brings forward plans for prescribing and other hosted services. In relation to prescribing, the executive summary provided sets out significant pressures in terms of both demographic growth and impact of an elderly population on our prescribing, and in terms of price growth, where we are largely at the hands of the national position in relation to nationally negotiated prices. So we have a significant level of pressures, but we've identified a number of savings plans. Most significantly, a really challenging target of £500,000 in relation to our quality, safety and efficiency prescribing programme, which will be delivered through a bespoke practice-by-practice approach using the robust data model that has been developed in 18-19. A gap of 752,000 remains in the prescribing financial plan, and it's hoped that, at least in part, the further work to be taken forward, led by Hamish and the prescribing team locally around non-medicines prescribing, will go some way to close that gap, and we will keep the IGB informed on progress. It is worth noting at this point, and members will be well aware, that the volatility of prescribing expenditure, which is influenced by nationally negotiated price positions, profit sharing arrangements with our community pharmacists across Scotland, means that we just as normal see fluctuations regardless of the plans that we set, and it's just important to remember that moving forward. Just briefly for prison healthcare, again the executive summary sets out very significant pressures and essential service developments, reflecting the increasing population, the inspection improvement plan arising from the external inspection during 2018-19, the focus on achieving the commitments as part of the Scottish Government's mental health strategy for the prison, and the impact of smoke-free prisons. However, despite significant pressures on essential service developments, we were able to present a balanced financial plan for 1920, which is largely due to our success in negotiating £532,000 of NHS Tayside's £2 million NRAC funding allocation for 1920, which, along with significant investment from all 3 IJBs and indeed all 3 ADPs across Tayside, to deliver on their commitments, we're able to present a balanced financial plan. For other hosted services, we have no significant financial pressures other than pay, and that is offset by the pay uplift that NHS Tayside has provided. Overall, therefore, if we take the core health services position along with the position for prescribing and other hosted services, the gap in the financial plan, formal gap, rises to 3.59 million, and as I've mentioned, a formal recovery plan has now been developed to respond to that. However, it's important to know that inpatient mental health remains an area where we don't yet have a financial plan. It's still work in progress, but we still anticipate bringing that forward to the September IJB meeting. Both plans and the executive summaries have been through an intensive BRG scrutiny process, and a number of challenges were brought to officers, but the pressures and the savings have been endorsed. Callum, I don't know if you want to say anything.
Just very briefly to add to what Mrs Smith has said, yes, we had a IGB budget review group meeting to look at these proposals, and we're happy to endorse them after some of the questions that we had were answered. I think it's obviously a step in the right direction that we managed to have the 3-year financial plan for the core health and social care budget earlier on in the year. It is still a concern that we do have the GP prescribing budget, the hosted services budget coming later, although that's still significantly earlier on than the inpatient mental health, and there are still problems with getting information from NHS Tayside for the production of these budgets. So I think it's a step in the right direction, but there is still much work to be done. I also think it's very positive that the work on the financial recovery plan is happening earlier this year than it did last year as well, and we have a budget review group I think during the summer recess to look at how we bring in some more actions to try and deal with the current projected overspend for the whole budget. So I think that's being much more proactive than last year, so there are all positive steps.
Thank you, Callum and Jane. Are there any questions with regard to this paper? Sander?
It's not so much a question, just as a comment. I think the partnership officers have done a significant amount of work around the recovery plan, indeed with the chief executives of the organisation. But I think it was brought up by Councillor Purvis there in relation to a lot of the problems that the BRG experienced this year was a lack of information flow from NHS Tayside, not a lack of being asked for information, but actually them handing it over in the timely manner that was required. And I think that I know that some of our colleagues have been pushing for that, and that's positive, but I think it's important that, given the responsibilities that we are required to discharge, that information flow is much is much more forthcoming in the future, because it really does make it very difficult for our officers to actually try and financially plan going forward, and it makes it difficult for the BRG as well.
I think we can hope that that situation will be further improved this year. Eric?
Thank you, Chair. Yeah, I just wanted to pick up on one figure in particular in the detailed Appendix 1 in relation to, and it's number 5, and in relation to the Quality, Safety and Efficiency Prescribing Programme, where, to quote, and I quote, it says, a broad target of 500k for 2019-20 has been set. So, you know, it's a target, you know, and no doubt a very stretching target to achieve that, especially as we're already 3 months into the year. And yet, despite, you know, even if that target is achieved, there's still a $750,000, just over $750,000 shortfall on the GP prescribing budget. And I just wonder, against that background, how realistic is it to conclude at 5.3 that the Chief Officer will bring further proposals forward to the IJB to support a break-even position for GP prescribing?
First of all, taking the quality improvement programme, I think what we've seen in 18-19, Hamish may want to come in here, is evidence that the work that we're doing around variation with our GPs is having an actual impact on levels of expenditure, and we have been able to evidence that. And that has given a confidence to the target that's been set, which, whilst it's a round figure, behind that does sit a review of practice by practice and the level of savings that we believe can be attained, and a prudent approach, recognising that some GPs are already engaged fully in the programme and other GP practices have, you know, there's still some work to do in that respect. So all of that has been built in. So there is more science to it than you might be led to believe by the global figure. In terms of the gap and bringing forward further proposals, that is particularly with respect to the non-medicines prescribing project, where we're pulling together an Invest to Save proposal, and there is significant opportunity from that proposal. The challenge will be whether we can deliver it, how quickly we can deliver it in this financial year. But in terms of the overall scope, it is significant. Plus, we are working across Tayside on a number of other plans that are not yet reflected in the financial plan before you today.
Okay, thanks for that. So you're giving a reasonable degree of assurance, if in audit speak, if you like, a reasonable degree of assurance that the 500k figure is broadly achievable in this financial year in terms of the target?
Yes.
Yeah.
Otherwise, we wouldn't have put it in as such. Yeah.
Yeah, I'll just make perhaps a couple of comments. I'm going to come to them later in the paper. I think firstly at the outset, I would still say I would question the adequacy of the overall budget. That we are still facing this overspend. We made a strong case on behalf of Perth and Kinross for the £1.2 million which NHS Tayside apportioned to prescribing, and we have now got an even split of that, although we asked for a much higher basis, a much higher proportion of that to rectify what we see as an inadequate budget, and we'll continue to argue that case, but that improves our position for the coming year by an additional allocation to P&K of 200,000. In terms of the 500,000, we know from our variance to Scottish prescribing spends that there is, if we got every drug down to the Scottish average, now that's not to say that's best practice medically, but if we were, then there is significantly more than £500,000 opportunity for savings. But I would emphasise that may not be good clinical practice, but there is some justification for putting in a figure like that, although I would say it is a challenging figure that we're presenting, but we're certainly seeking to bring all we can forward with that. And I would also emphasise that, again, I was going to mention it later, that 18 out of the last 22 months in Perth and Kinross, our prescribing has dropped at a greater rate than across Scotland. So we are working very hard, and we are seeing improvements of 1.1 million reduction last year. But a lot of the variances that we see are out with our control.
Hamish obviously raises the issue of the inadequacy or our view of the inadequacy of the budget, and it's certainly a discussion that will continue with our colleagues within NHS Tayside. Colin?
Thank you, Chair. Just on the question of the adequacy of the budget, am I right in thinking that for previous years we have formally recorded that the budget for prescribing was not adequate as a formal record of the IJB, and if that's the best advice from our Associate Medical Director, it might be worth incorporating that into any resolution that we come to on the paper before us today.
Just to clarify that point, at inception of the IGB, following the due diligence exercise, we were clear that the budget was insufficient at that stage and wrote to NHS Tayside on that basis. However, in subsequent years, while we've presented a gap in the financial plan, the IGB endorsed approach that was around working with NHS Tayside to develop a 3-year financial plan to resolve the underlying overspend.
I think it's certainly something we can look at the wording within the minutes, and obviously the discussion has been around our view of the continuing inadequacy of the budget, but actually that we would hope to pursue that through further discussions with the NHS Tayside. Are we happy with that, Eric?
Just a further question, not related to previous discussions. I'm just seeking a bit of clarity. Having attended the Audit and Performance Committee that we shall hear about, no doubt, shortly, reference was made and emphasis was placed on the need for the IJB to issue directions to NHS Tayside and to Perth and Kinross Council. Indeed, I see in the covering papers here reference to this being a legal requirement of the IJB, and I'm just wondering if there are any issues we need to be concerned about the fact that we haven't been doing that in the past, issuing directions.
I think it's been noted that we haven't issued them in the past, but you'll see obviously as part of the papers today, and certainly one of the recommendations in this report is actually that the Chief Officer issue the necessary directions which are attached as one of the appendices.
I'm really just asking whether there is any legal issue regarding the non-issue of directions in the last 2 years.
I'm not sure if anyone can answer that question, perhaps, Jane. I know it was noted by the auditors, but I don't recall the discussion last week that there was any suggestion that there would be any legal repercussions with regard to that.
I don't believe there are any specific legal repercussions. I mean, certainly across Scotland, there are a number of IJBs who, similar to Perth and Kinross, are going through a kind of ongoing process to make sure that this is an established part of our business process. We have issued directions in relation to the financial plan that was agreed in March. We are issuing directions now in relation to the further papers where decisions are required by the IJB at this meeting. Will continue to do so. But if it's a comfort to IJB members, we can certainly, with our legal support from Lisa Simpson, make sure that that's absolutely clear.
Are there any further comments in relation to this paper? We're happy to note or to approve the recommendations 1.1, 1.2, 3, which is with regard to issuing of direction, and to note recommendation 1.4. Yes? Okay. Thank you, which takes us now to item 7.5. Callum, there was an audit and performance committee last week. Could you give us an update, please?
Yeah, thank you. We had an audit and performance committee last Tuesday, the 18th of June. I'll just run through a few of the things that was discussed at that meeting, just to pick up on the point that Councillor Drysdale raised in relation to directions. One of the things that the audit and performance committee had asked for in preparation for directions becoming a regular part of the committee meetings and decisions that the IJB takes was a briefing note to be issued to all the IJB members to outline what a direction was and when it should be used to help with the scrutiny of any directions that are included with the papers. That has been circulated, so you all should have had that in advance of this meeting. Just to run through a few of the other things, the substantive items on the agenda, we had an update on the strategic risk management, the risk register. The only exception that was noted was that the financial residual risk had reduced, not significantly, but from 25 to 20 following the setting of the 3-year budget and some other factors, although the mitigation measures to try and address the financial risks in future were also updated. There's a number of things which tie together, and perhaps this might be discussed by the Chief Officer in his report. But for a while now we've had the Transforming Governance Action Plan, as well as a number of other ways of monitoring updates and action points that have been agreed either at the Audit and Performance Committee or at the IJB as part of our ongoing process of ensuring that we have the appropriate governance arrangements in place for the IJB. This is going to be subsumed into an improvement plan for 1920, which will also focus on a number of other areas that have been highlighted by the Ministerial Strategic Group's review of progress for the integration of health and social care, and also presumably the outcome of any recommendations from the inspection report, the joint inspection that the Perth and Kinross Health and Social Care Partnership had. So those things will be carried over. There are a number which have been in the Transforming Governance Action Plan for some time and do need to be progressed. But our hope would be that once we can start afresh with taking all of these things into account and the various reports that have been published, the MSG, the Audit Scotland report, and our own joint inspection report, we'll be able to progress for the rest of the year and going forward with this new improvement plan. So further to come on that, and as I said, perhaps the Chief Officer might comment on that. In terms of audit, we had the internal audit report, the annual report from the auditors. This was quite useful in bringing together a number of the things which had been threaded through the various papers that we have had. Most of these, the themes had been raised before, but one of the clear recommendations that came out of that, we are working to set up the new clinical care and professional governance committee, because the IGB identified that there was a deficit in terms of our assurance over clinical care and professional governance. And the Chief Internal Auditor's recommendation was that we progress that rather than trying to sort out all the specifics, but actually progress that, because at the minute there's a gap in terms of assurance, and we're getting to the stage where some of the things in like internal audit updates that would have been going to the Audit and Performance Committee relating to care governance are now supposed to be going to that committee, but the committee hasn't started. So the clear recommendation was to get it up and running as soon as possible. We also appointed the internal auditors only for 1 year. The original proposal was to appoint Jackie Clark, who is the Council's Chief Internal Auditor, for 3 years. I decided that it would be best to appoint her to replace Tony Gaskin for 1 year, while we asked officers to look at all the options that are available to the Audit and Performance Committee in terms of how we can discharge our internal audit functions, and then we will review that next year. We also had the draft annual accounts and the annual governance statement that we approved for recommendation to the IGB for approval. In terms of the annual governance statement, this year we received assurance from both Perth and Kinross Council and from NHS Tayside that the adequate governance arrangements from both our partner organisations had been in place. And this was obviously different from what happened last year, when NHS Tayside was not able to provide us with assurance that the adequate governance arrangements had been in place for 2017-18. After a discussion, we were also able to approve the draft annual accounts to be recommended to the Integration Joint Board today for formal approval. Just to touch on corporate performance reporting, that was something that was incorporated as part of the new terms of reference for the Audit and Performance Committee. However, we don't tend to have, and have not as yet had, any complaints on a strategic level across the whole of the IGB, and most of the complaints are specifically clinical and care governance related complaints. So it was thought that those would be more appropriate to go to the Clinical Care and Professional Governance Committee when that's set up, and we will just now have an annual report to the Audit and Performance Committee about complaints. We're also going to have a special meeting of the Audit and Performance Committee during the summer recess to consider the annual performance report for 2018-19. I know there was many people who had different views on how this report, the format of it, and what information it should convey last year. So I think it was important that we had the time to put that feedback to the officers, and also for it to have the appropriate scrutiny when it comes to the Audit and Performance Committee. So that will be happening during the summer recess. Just in terms of moving forward, one of the things which I'll touch on in the annual report is a concern has been the lack of performance reporting to the Audit and Performance Committee. We did have at the last committee our first performance report for the Older People and Unscheduled Care Board. We were supposed to have reports from some of the other boards to the Audit and Performance Committee at our meeting last week, but unfortunately that was not able to happen for a number of reasons. So we are expecting a report which will cover an update on the performance of all 4 programme of care boards at the next Audit and Performance Committee, the next regular one in September. And just finally, I've asked for updates, one at each meeting from the localities, because obviously the localities are a very important way of how way in which we deliver our services, but there doesn't seem to be a method by which they report to any part of the IGAB at the moment. So I thought it would be useful for Audit and Performance Committee members to get a better understanding of what is going on in localities, and I think we're expecting to have our first update from a locality at the meeting in September as well. But happy to take any questions on that.
Thanks very much, Callum. Any comments or questions, Andrew?
Yeah, it's maybe not a question for Callum, maybe a question for the Chief Officer in terms of where are we in terms of establishing the Clinical Care and Professional Governance Committee, because I've just checked and we did agree the terms of reference back in November last year, obviously before your time, but...
Yes, so I have a meeting this week with the Chief Social Work Officer and Associate Medical Director to confirm the intended agenda that we'll discuss with Councillor Stewart, who will be chairing that committee. I anticipate that we will seek to convene a committee in the course of July or into early August, and we'll be working up papers between now and then in order to support that committee's scrutiny.
Okay, thank you.
Thank you, Chair. Councillor Purvis, thank you for your comprehensive update on the Audit Committee, and it's good to see effective governance being put in place. My question is a very specific one, and you noted that you'd taken a decision to appoint the internal auditor for a period of 1 year. In normal circumstances, the appointment of internal audit would come to the full board. It's so that there is a good governance and responsibility by every member around this table, every voting member around this table. So that's just a point for consideration into the future. And my second point pertains to a discussion that actually we've just had, and Chair, if you agree, we noted that it's very helpful to have the Audit Committee undertake interrogation and indeed assurance in relation to performance, but there is a requirement that performance reporting is interrogated by the full IGB, sitting alongside that strategic risk and indeed health and safety. So we agreed with the Chair and the Vice Chair just prior to this meeting that we would expect those 3 items to be standing items on the agenda of the full IGB, as well as interrogation by the Audit Committee.
Okay, thank you for those points.
Eric?
Can I just follow on from that point regarding the analysis of performance data? I mean, it really has been sadly lacking over a number of consecutive meetings. It's been pretty sparse. It does sound like an audit committee rather than an audit and performance committee at present. And I fully take on board the Chief Executive's comments that that data should also come to this forum for further analysis and scrutiny. And can I ask, please, that when it does come, that insofar as it is possible, and I appreciate it, we're on a journey here, but as far as possible, can the performance data in some way be compared and benchmarked to national data so that we can see how we're doing in comparison with our peers? Thank you.
Thank you, Councillor Dryce. I have asked to see the draft report that's coming to the next meeting before we have the pre-agenda stage even. So I'll make any comments and hopefully feed that back if it's not. But I think maybe Gordon was wanting to.
Gordon, do you want to comment with regard to any of that, the benchmarking particularly, perhaps?
Yes, absolutely. I mean, I think Councillor Drysdale's points are well made and have resonance with my early analysis of our ability to deliver regular, routine, effective performance information to the IGB. And I suppose more so operationally and managerially in terms of our ambition to satisfy ourselves that we are delivering what we set out to do, and that we know we are, and we know how we are improving in any number of areas. So certainly it is going to be a priority moving forward that we will be developing a very robust performance framework in relation to all the work streams that we are delivering on, so that we are clear about how well we are making progress, what difference we're making, and how that links to the strategic plan. So I can give you that assurance, and the benchmarking will be nationally, it will be over time, and it will be over against comparator health and social care partnerships.
Thank you, Gordon. Sander?
Yeah, it's just a comment really. I think it sort of follows on a bit from both Councillor Drysdale's point and Karen's point as well, around, I think there is a need for the IGB to see more information. I think we are beginning to see that. And I think also the steady membership at both the IGB board level, at the Audit and Performance Committee level, etc., will start to help with the scrutiny of information. I think it's positive that we're, and as you know, Councillor Drysdale said, we are on a journey, and some of us have been on the journey for a wee while, and we are in a much better place now than we were 2 years ago, but it's still quite far away from, I think, where we all would desire to get to. I think, from my point of view, I find it quite positive, the opportunity to be able to go along to the Audit and Performance Committee and take part, although I'm not a formal member. We've opened that up, and I think that's quite a useful thing to, further to the Chief Exec's point about we as board members should have assurance. I think that does give me a bit of assurance that I can go along and ask questions as well. I think that sort of transparency is something that is quite positive going forward for us, and that we should be moving ahead in that sort of mould and trying to maximise that style of working.
Thanks for those comments, Andy. Happy to move on, which does take us to the annual report from the Audit and Performance Committee. It's the first annual report. Callum, thank you for presenting it today. Would you like to highlight any specific points from your report?
I think a lot of the things have been mentioned before, and the report does provide a basic overview of what's happened in the year. We have made a number of positive step forwards in terms of the refresh of the terms of reference, which has helped both with the governance of the committee, but also, as Councillor McDade alluded to, opening it up to more members of the IGB to get involved as well, and also clarifying the duties and its responsibilities. As we go forward, we need to make sure that we have the appropriate assurance to the IGB for all aspects of the health and social care partnership. We did identify the gap, as has been discussed, in terms of clinical care and professional governance assurance, which will be addressed by the establishment of the new committee. But just to pick up on the point that the Chief Executive made, and has been made by others, there does seem to be still a deficit in terms of the performance reporting, and while we have been pushing to try and improve that, I think that there is perhaps a discussion that now needs to be had about the role of the Audit and Performance Committee in terms of its performance responsibilities. It is quite a wide remit in terms of audit, risk, governance, assurance, and for a service delivery-based organisation, that's what we're here to provide. And performance is as crucial, if not more so, than some of the other aspects that we see. So absolutely, we need to ensure that in future the IGB sees that data and that information on performance reporting. But there is perhaps a question about is there a need for a committee or subcommittee that looks specifically at reviewing performance-related data. And we have had some initial discussions around that. But those are further discussions that need to take place. So I think we have made some steps forward in terms of the refresh of the terms of reference, the improvements in terms of the governance arrangements. I think that certainly from the meeting that I first chaired as chair of the Audit and Performance Committee, I think that the level of questioning and engagement has certainly increased and improved. And as Councillor McDade said, we now seem to have a steadier membership of that committee. So I think that there has been a lot of progress over the year, but there are some still key points about how we make sure that this board has the assurance that it needs across all aspects of the health and social care partnership.
Thank you, Callum. Are there any questions for Callum with regard to the annual report or any comments? Karen?
Thank you. Councillor Purvis, just to be really clear in the earlier point I was making, I think I was supporting your position in terms of the role of the Audit and Risk Committee in terms of the due diligence that it brings to scrutinising and interrogating performance information, and I think that needs to continue. My plea, if it wasn't articulated well, is that it's actually a responsibility of everyone round this table, not just something that should be placed upon Councillor Purvis's shoulders. My suggestion is that it is a standing item, and that it is brought back here for that very reason. So it's not to diminish the role of the Audit Committee, it's actually to enhance it.
Just to respond to that, no, absolutely. That was what I took from your point. I think it was just, I obviously wasn't privy to the discussions earlier on, so perhaps need to catch up with people on that. But prior to those discussions, we have had separate discussions about, I suppose it's quite unique in terms of other contexts and other public boards of having an audit and a performance committee, an audit and a risk committee, or an audit and finance. There's lots of different iterations that you can have, but audit and performance can be quite distinct areas. And I think that there is still a need when we're looking at the agenda for the next committee, when we're starting to have all of those reports from the performance side, both in terms of the programme of care boards and also the localities. That can become quite an unwieldy agenda along with all the governance arrangements as well. So there's been identified as a need for a separate clinical care and professional governance committee, but there is still a question about, in addition to absolutely the need to bring that information to the IGB, and for all IGB board members to have the responsibility to look at that performance information, but whether or not we need to look at separating out the audit and performance functions.
I think you're both agreeing with each other, so and I think we're agreeing with you also, so we'll look forward to the opportunity of all board members being able to fulfil their governance responsibilities by seeing the necessary information in relation to performance, risk and health and safety. If there's nothing further, can we note the recommendations? 3 points to that: acknowledging the report, noting the report and instructing Callum to bring a further report next year, and the input from members of the Audit Performance Committee to the work of the committee, and also to, it's not in the recommendation, but to thank Callum for chairing the committee. He picked up partway through the year, but also to thank Councillor Ahern for his chairing of the committee the beginning of the last financial year. Thank you. That takes us to item 7.3, which is our unaudited annual accounts for 2018-19. You have those before you, kind of covering report. You'll see that demonstrates or evidences a considerable amount of work from Jane and our colleagues and a number of people that have contributed to the annual accounts. It's a lot of work that goes into a fairly short timescale. So thank you for bringing those to the IGB today. Jane, is there anything, it's a lot of information to summarise, but is there anything that you would like to highlight in particular?
No, just to summarise that the annual accounts have been through the Audit and Performance Committee, as we've just heard. The Audit and Performance Committee have approved the annual governance statement, which now sits in the annual accounts that you have before you today. Really just to ask for the IGB to approve the unaudited accounts to be signed by me, to be released to external audit, and at the same time be made available for public inspection.
Before we do that, and coming to recommendation, are there any comments or questions with regard to the annual accounts? Xander?
Thank you, Chair. I mean, I made the exact same comment at this morning's Council Audit Committee, so you'll have to forgive me, Councillor Drysdale, for repeating myself. I appreciate the level of work that has to go into the. I'm just before I start, not fully in agreement with the accounts. So I'm not challenging anything like that. My issue is around the time that members have for scrutinising such a comprehensive document, because the rules require that this is submitted by the 30th of June, and therefore if there were in future, for example, any issues that the board did take with them, it does not allow much time for any reassurance to be provided afterwards, and I think it comes down more to the timings of the meetings, and I realise that there is pressures on officers to prepare these things, but from my point of view it was more around getting the accounts to us as board members earlier than sort of a week before they're due to go in, so that was kind of my point.
Thank you. Sorry, as you said, the timescales are tight. I'm sure officers and along with Gordon will look if there's any opportunity for next year to kind of improve that situation, and I'm sure we'll try and do that. Jane?
I should just say that these are draft accounts, and if there are any particular issues that you would want for us to take on board and pass on through the process of external audit, be very happy to do so.
No, absolutely, I appreciate that. It was it's more about process and as I say, no problem with these ones. It's just from a sort of governance and process point of view, it's good to be able to catch anything as early as possible, and the earlier we see them the better, as it were.
Any further questions or comments? Happy for us to proceed with the process? Okay, thank you very much. Thank you very much, Jane, and your colleagues for getting us to this stage with the annual accounts. If we could now move to agenda item 8, which is about the development of strategic objectives, one report within that section, and then we'll stop for a short break. But Gordon, could I ask you to provide us with your strategic update? We have a report. Would you like to highlight points from your report?
Yes, thanks very much, Chair. So I have summarised some of the key considerations that I think that the IJB need to be appraised of and updated in relation to. What I'll do is speak briefly. I assume people will have seen what's in the report. I'll summarise some of the key points, and we can perhaps take questions in relation to each item as we go. Firstly, the Strategic Commissioning Plan. As IJB members will be aware, earlier this year it was agreed that we would defer the publication of our Strategic Commissioning Plan in order to both respond to the Ministerial Strategic Group's review, the inspection, and to recognise my own appointment and coming in as the new Chief Officer. So we have embarked upon a significant amount of work in relation to the development of the Strategic Commissioning Plan, which many members will be aware of, having participated on the 5th of June in this room in, I think, a very helpful, positive, rich discussion around our ambition, the strategic ambition for the partnership, and IGB members' aspirations for how we should go forward and develop the plan, and the key aspects of that we would seek to deliver on. Beyond that, we are now about to kick off a process of engagement. So what we've identified is that we will inform the development of the plan through what we already know, because we have been in conversation with groups and partnerships and third sector and other organisations for some time. We will supplement that by engaging with those groups with whom we're already connected, and we will develop some bespoke engagement in and around local communities that will seek to ask people about their priorities for the Health and Social Care Partnership, to enable them to inform the strategic direction and the actions that fall from that. So that process is underway, well, about to commence at the moment, and that will enable us throughout July to seek to engage much more fully in a way that supports the drafting of the Strategic Commissioning Plan in the month of August, ahead of our intention to bring it to the IJB as requested on the 27th of September. I'll maybe pause there if anyone would wish to ask me any questions about the Strategic Commissioning Plan.
Thank you, and thank you to the Chief Officer for the progress that's been made on this and the update there. I think that's very positive, and as a person who has complained probably most about the lack of progress, I'm delighted to see the progress, so thank you. I'm just wanting to query about, I think it's very positive, we're going to go out and consult over the summer period. What I wanted clarification around was that IGB members will see a draft before it comes before this committee for final approval in September.
So we will be looking to draft it in early August, and can either address that request by correspondence or potentially look at a development session at that stage to review the progress we have made, and to seek any guidance on further work that might need to be done. So we will make sure that you see it before the 27th, or the week before, or the 2 weeks before, when the papers come out.
I think that would be very helpful. A development session might be more useful, but yeah, absolutely, either of those would be gratefully received. Thank you.
Got there, sorry. So the joint inspection, just a brief update in relation to the joint inspection. We had met with the inspection team in the middle of May and received some feedback from them in relation to the field work that they had carried out. We have subsequently considered that feedback and the presentation that they delivered to us, and have identified the potential for us to provide them with more evidence, to engage more fully, and to provide further representations to, we think, enable them to better understand the journey that the partnership has gone through, the ambition of the new senior leadership team, and some of the challenges and improvements that we have initiated. So what we've done is we've gone back to the inspectorates and secured a further meeting. We are trying to set that up. It's proving quite challenging, obviously, with the summer recess. We will look to have further discussions with the inspectorate before we settle on a final draft of the inspection report. Our ambition is that is gives greater recognition to the context and to the achievements we've made, that it has balance insofar as we think that there are lots of aspects of our performance that we are beginning to see signs of improvement in relation to, and we would like that to be reflected. And that we're very much looking forward to receiving a report that supports us on an improvement journey and identifies the inspectorate's views on where we might go next in relation to those aspects of our performance where we are perhaps not achieving as well as we might want to. Many of which we are already cited on, and many of which we are already working on. So a further meeting, a delay in the publication of the report, and future updates as necessary.
Sander?
Yeah, thanks. Two questions around that. Just wondering if you can give us a bit more information, Gordon, around what the further evidence that you've been providing is, and also when we might now expect a final completion date and report publication.
Certainly, yes. We had provided the inspectorate with significant evidence after our self-evaluation, and have, in the course of the more recent discussions, recognised that the volume perhaps precluded them from identifying the specific evidence pertaining to some aspects of what it was they were looking at. So we've pointed that out to them and sought to supplement it. It relates generally to the overarching themes of the inspection, which is about strategic commissioning, it's about performance reporting, it's about our engagement, and it's about strategic leadership. So there are aspects of that we think that we can provide further information that the inspectors will hopefully take into account. In terms of timescales, the difficulties that we are having around setting a meeting to enable us to have the discussions, to enable the inspectors then to reflect on that further evidence, make it quite difficult beyond saying towards the end of the summer, I think, at this stage.
Okay, thank you. So we're likely probably to have it before our next IJB meeting at the end of September then? With as much assurance as you can give us, basically.
That really depends how long the summer's going to be.
Is it an Indian summer or not is the question.
We will endeavour to have it and have the findings ahead of the IGB on the 27th of September, certainly.
Karen, would you like to comment?
Thank you, Chair. Councillor McDade, it's a matter for the inspectorates when they choose to publish a report, and we will be given notice of the date of that and 1 week embargo in terms of a copy of the report.
Thank you, Karen. Gordon?
Thank you. So the next item that I wish to update the IGB on relates to the independent inquiry into mental health services in Tayside. And as you'll see from the contribution that I've made to this agenda through the report that you have before you, we need to acknowledge that the independent inquiry published an interim report on the 22nd of May. We have been working, the 3 IGB chief officers, with NHS Tayside to look at the recommendations and the actions, the aspects of that report that have highlighted areas for improvement, and on the back of which an improvement and action plan is currently being developed. We have also, I think we have to acknowledge that the NHS board chairman commissioned this independent inquiry along with the previous interim chief executive. And it is the intention of the NHS board to receive a report from officers tomorrow, and to invite David Strang, the author of the interim report and the chair of the independent inquiry, to tomorrow's NHS board. What we have recognised as chief officers with the chief executive of NHS Tayside are that some of these some aspects of what is covered in the report are delegated matters, some are hosted, and some remain the preserve of NHS Tayside. The independent inquiry is looking at end-to-end care in relation to mental health, and it is important that we recognise the collective contribution that each of those partners can make to developing an action plan and to delivering improvements across the whole system. However, it has to be recognised that the focus of the interim report is very much on inpatient mental health services. And as members will not need to be reminded, that is a hosted service that is the responsibility of this IJB. My intention, in view of the sequencing of the various meetings, is that we will need to consider beyond tomorrow's NHS board whether we convene additional special IJB over the next few weeks in order to discuss the matters that come out of the NHS board in relation to Mr Strang's request that we carry out a review of the risks associated with inpatient mental health in the current redesign programme. We're not in a position to report on that today, to give the NHS board their place tomorrow, and to recognise that Mr Strang is appearing at the board at the invitation of the chairman, John Brown. So I would suggest to the IJB that beyond tomorrow's meeting I'll have a discussion with the chair and vice chair, and in order to consider any reports that are being developed in response to the interim inquiry, we may well have to convene a further meeting of the IJB to look specifically at any recommendations, challenges or proposals in and around the hosted service of inpatient mental health. So unfortunately the timing and sequencing makes that quite difficult. It would be far preferable had the NHS board already responded to David Strang's report and we had the opportunity thereafter to consider the implications. However, the chairman of NHS Tayside and Grant Archibald, the chief executive, are acutely aware that the matters pertaining to inpatient mental health are the responsibility of this IJB, so we will be seeking assurance from the board and advice about their response to the interim inquiry report to inform our future deliberations.
I've quite a few questions, if that's all right. First, I appreciate what you're saying about the fact that it's going to the NHS Tayside board tomorrow. and that the report was commissioned by the NHS Tayside Board. I had asked if the interim report could go to the Audit and Performance Committee, and was advised that it would be better to go to the Clinical Care and Professional Governance Committee, which was fine because that's the appropriate place for it, although that isn't set up yet. What I can't understand is why the report hasn't come to this committee when this is the first committee, regardless of which one is the appropriate one. If it's not appropriate for the Audit and Performance Committee, we don't have the Clinical Care and Professional Governance Committee. Why the report itself is not at this committee, and it's just an item as part of your report, why we don't have the people that we need having responsibility for inpatient mental health as the hosted service for Perth and Kinross Health and Social Care Partnership at this board, including Mr Strang, including the people who are responsible for inpatient mental health services, to answer our questions on the report. I'm not really sure I think that this is good enough, really, if I'm going to be perfectly honest.
Callum, I think the kind of key point is that the inquiry was commissioned by NHS Tayside, particularly the chair and the interim chief executive. It's important that that's considered by NHS Tayside board. So as Gordon's outlined, we then will have an opportunity, if members are happy for us to convene a special IJB at probably the end of next month, for us then to look at the report.
I have sorry, I had a few more, if that's all right, or do you want to go to others first?
Well, if the comments are in relation to your first point, then okay, Eric.
Yeah, I have to say I completely agree with Councillor Purvis. You know, the issue here, you know, okay, on the one hand we have protocol and the right order of things. On the other hand, what we have is a very, very important service that we're wanting to get right to the nub of whatever problems exist there and deal with them as expeditiously as possible. And you know, I would be very uncomfortable if we had to wait even another month or anything like that to have the opportunity to have a discussion. And for me, you know, given where we are and the fact that we're not being presented with this paper today, I would certainly look to or want to have this presented to us just as soon as humanly possible after tomorrow.
Sandy?
Yeah, I mean, I very much echo what Councillor Drysdale's just said and what Councillor Purvis has said. And I think from my point of view, some of us were sitting around the table when the initial decision was taken about the redesign, and we sought a lot of assurances at the time. It was a long discussion. We sought a lot of assurances about the model and weren't necessarily delighted about it, but were reassured that it was supposed to be the safest model for patients. We now have an independent inquiry report which seems to be indicating that there may be actions that need to come out of that, and as the body that's responsible for commissioning the service, given that we have a meeting today, I would have liked to have seen that report before us today, and I certainly want to see it, as Councillor Drysdale says, as soon as humanly possible, and a meeting scheduled to discuss that within as soon as possible after the NHS Tayside board has met, basically.
I think we can note these concerns. I think in terms of a meeting for us to consider it, it's for that to be as informed as it can be, and I think with annual leave, certainly Gordon's annual leave and other, we need to look at what would be most helpful in terms of the date for a report. So out with the meeting, we'll try to set up a meeting that's going to be as helpful to everyone as possible. I think it's important that, you know, our chief officer is part of those discussions. We have the right people who are able to advise us with regard to the contents of that report and to give full consideration to the report. So I think we need to look at what's the best date to do that, and obviously to
which is why today would have been a good day.
Well, unfortunately, Councillor Drysdale, it's not today, and I think as explained, this needs to go to NHS Tayside board, which is where it's going tomorrow.
So thanks for that. I appreciate the comments, and I take very seriously the concerns that members have expressed about not having the report before them today. I took the judgment that it was necessary, along with the other chief officers who have also not presented, for example, to Dundee's IJB a response to Mr Strang's report earlier this week. I took the view that it was important to respect the fact that the chairman of the NHS Tayside had commissioned the report, and to reiterate that Mr Strang is going to be meeting with NHS Tayside board members tomorrow. Putting aside the challenges around sequencing and process, I now feel as if an ice cream would be a good idea. Thanks, Sandra. I think it's probably really important that IJB members be reassured that we are collectively taking very seriously the findings in the Strang report and David Strang's report. We are sensitive to the fact that it is raising serious concerns about aspects of the service, and we have developed a series of actions to seek to address those concerns. The other aspects of that are, though, that some work was already underway in relation to some of the concerns that have been raised because we were aware of them and they had been raised in previous reports. What we don't know is whether that is a contemporary account of people's experience, but in some respects that matters less than satisfying ourselves and in due course the IJB that improvement actions have been taken to mitigate some of the risks that have been flagged up and to take very seriously the findings of the interim report.
Okay, thanks, Gordon. Before we go back to you, Callum, Karen, you had a question or comment?
I've got a comment, thank you, Chair. A few comments, actually, if you don't mind. The first thing to say is that I fully understand the position of the elected members on the Integration Joint Board in terms of the report coming here. I think that's something we would all absolutely support. However, we must be careful in terms of it was the chair of NHS Tayside and the previous interim chief exec who commissioned this report, and it's right and proper that it's considered by them first off, given they were the commissioners. The second part, my observation is that my understanding is this report is an interim report, and at the moment it specifically and exclusively hones in on the experience of those who have accessed mental health services in Tayside. So, as I understand it, having spoken to the Chief Executive of NHS Tayside, there may or may not be a further piece of work required in relation to the report, the interim report that is being discussed at tomorrow's NHS Tayside meeting. I do have assurance from the Chief Executive of NHS Tayside that he fully understands the governance responsibilities of this Integration Joint Board, and he will in future ensure that those are recognised and adhered to.
Thanks for those comments, Karen. Callum, you had other points you wanted to...
Yeah, I think just initially with a comment, I was not myself a board member at the time, nor was, I think, Councillor Stewart, but we did have concerns about the way in which these proposals were brought forward, and the fact that only one option went out for public consultation. And I understand that the reasons that the officers gave for doing that in terms of saying that it was the only clinically safe option. But I think that the problem is that the engagement has not been, there has not been sufficient engagement with the wider service users and stakeholders at that time. It's very difficult because if there's not people here to answer my questions, then I do wonder what the point in asking them is. But clearly there's a clear recommendation in here about the need for a comprehensive review, while accepting that this is indeed an interim report, and saying that the proposed changes should not be implemented before such a comprehensive review has been undertaken. I'm just wondering if we could get an update on the changes. I know that it was June 2020, I think, was the original date for when the programme was to be completed in its entirety, but I think not all of the changes have yet been implemented, and I'm just wondering if we could get an update on where those changes that were agreed are at the moment.
Well, I'm not sure if Gordon can do that, but I think certainly when we have our special meeting, then we'll be able to get that information, unless you have further information at the moment.
At the moment, we are at the stage where the redesign of the Rannoch ward at Murray Royal Hospital is ready to accommodate service users patients from the Learning Disability Assessment Unit. However, we are having discussions about staff around the arrangements for transitioning. Now, I think that Robert's absolutely correct that that is either something that we received some information about when we last met as an IJB and had representatives talking in considerable detail about the redesign programme, or is potentially something that we can update on in the context of both a response to the interim report and in terms of providing information to the IJB about the extensive quality improvement action plan that has been developed. The only other thing I would say in that regard is I don't wish to put Alan Drummond under any pressure here, but he also has a key role and is supporting us in working with the staff to think about transitioning up to the new service at Murray Royal. Don't know, Alan, if you want to add anything. Or
Yes, I'm quite happy to update where we are. We seem to be somewhat in a bit of a lull of a holding position at this moment in time, and I think tomorrow we'll make a decision. The decision will be made at the board tomorrow as to whether we progress or not, because we seem to be in a holding position because we were going to progress with LDAU to move to Ranach, but that has actually been, the transition team's in a holding position for that at this moment in time. I've just got one question, Chair, for the Chief Officer. I'm looking for reassurance that if option 3A takes, if there are additional beds to be taken out of the system, that has to come back here to be ratified.
So, yes, so absolutely. I think probably what we need to do is to recognise that there are various aspects to this. One of them is about what were the decisions that were made at that time in January last year when the IJB determined that the proposed model around redesign should be taken forward, and also what are the particular what is the current situation with regard to some of the challenges around the accommodation and the workforce that will require us to reflect on whether or not we can support the same number of beds, or whether or not we can create the opportunity for some redesign that includes an investment, a further investment into community services by way of the home response team and the home support team and the crisis response team. So that would be part of the proposal that we would be potentially bringing to the IJB in the context of both a response to the interim report and an update in relation to service redesign.
Thanks, Gordon.
I think
Callum,
just a number of other points. I think that highlights my concern when you were talking about, Mr Drummond, that the NHS Tayside board will decide that tomorrow, when it's certainly in relation to inpatient mental health hosted services, it's for this board to decide on the strategic direction and any options that we want going forward. I think clearly from anyone reading this report, it's clear that we're not getting it right at the moment, and particularly in relation to inpatient mental health services. And if we've got a suggestion here saying that the proposed changes should not be implemented, or certainly further implemented, before that review's been undertaken, that for so long as we leave this, that we're continuing to perpetuate these problems. And as I've said before, I don't think that's good enough. There's a number of other, I know that I think the NHS Tayside are undertaking a risk assessment, and because I'm not on the board, I'm not sure whether that's something that they'll be discussing tomorrow. There was also a report that Bill Nicholl undertook, but certainly I haven't seen that as a member of the Integration Joint Board, despite the fact that that was looking, I think, at inpatient mental health services, an internal report. I think what I would like from this committee as a resolution of the board is that there is a cast iron firm guarantee that there will be a meeting within a set period of time of this board, where we will have the full information in order to make any decisions and discharge our responsibilities in relation to inpatient mental health services, and have the appropriate people here, both from the inquiry and from the people who are responsible for inpatient mental health services, to make an informed decision about what we do going forward. And I don't think it's good enough just to leave that as something that we might do. I would like a firm commitment that we will have a meeting with those people there and with that information by a certain date.
Thanks. I don't think it was suggested that we might do it. I think it was suggested that we will do it. It would just have to get an appropriate date. Karen?
Thank you, Chair. It's absolutely appropriate, Councillor Purvis, that we do have that meeting, and within a time scale that is at the earliest opportunity. The only thing I would say is, whilst we can invite those individuals to attend, we can't mandate them to attend a meeting with us. So I'm referring to Mr Strang, for example.
Thank you. Just from a process point of view, my personal involvement with the IGB came quite late in the consultation process around mental health services. But I'm aware that colleagues raised repeatedly their concerns around the consultation process, and the lack of what they felt was the lack of consultation, and were told repeatedly that there was nothing that could be done at that stage. And I think that is of concern, to know that there was no route for the public partners to take these concerns forward.
Note your comments. My understanding is that there was a very significant consultation process, actually, for that exercise, the most extensive consultation that had been undertaken by NHS Tayside, and I think certainly we were provided with quite significant detail in terms of the consultation that was undertaken. I'm kind of not sure how helpful it's going to be for us to continue the discussion today. I appreciate the concerns that people have, I fully understand those, but I think until we have the NHS board meeting tomorrow and an opportunity for us to consider how best to organise our meeting, have the right people there, the right information pulled together to update members, then today we're lacking some of that information, and to continue to not give the right detail of responses that you would require is not going to help us very much, I don't think. So, sorry, okay, just very brief comments, and I do think we need to move on from this, because I don't think we're going to probably get the answers that are required today, other than a guarantee that we will organise a meeting which is going to suit as many people as possible during July.
Yeah, my only comment is in in regard to Sandra's comment, when you talked about there was a wide consultation, which was absolutely true. I think that the issue that was raised with the public partners within Perth and Kinross, and the concern of was that there were very few, and I want to quote, 5 people from Perth and Kinross that were at the open meeting in Tayside at the start of the consultation process. I'm not 100% sure that my 4 or 5 is absolutely correct, but that was our concern. So it's just so that that's made clear.
Yeah, thank you, Chair. I mean, I appreciate, and we don't need to go around the whole thing again and again. However, I do think, and I'm pleased that you said in July, I think that's the right approach to take. And I think we do need to have all the different reports in front of us. We need to have as many of the expert positions in front of us, and here to answer our questions as possible. I also think that as an IJB with the strategic responsibility for this, that should come with a recommendation from officers in terms of a direction that we will be issuing to NHS Tayside in relation to this. I think that this is very much our responsibility, and for Councillor Drysdale and I were the only 2, I think, sitting around the table at the time. It was a controversial decision at the time. We took it with the best advice that we had at the time. However, it wasn't without concern, and I think from our point of view, given that there are other people who are experts now raising concerns as well, the sooner we have this information in front of us, the absolutely better.
Absolutely. I'm going to move us on. I think it is important. I think it's really important that we work with NHS Tayside. I think we would all hopefully share what I'm going to say now, is that the most important thing is that we improve outcomes for people who use mental health services. Is fundamentally what I think we all want to achieve. So if we can get the information that we require to help that process, then that's what we'll endeavour to do next month. Sorry, is that a very final point, Karen?
It is actually, and you know, I appreciate that whilst mental health services are hosted by this IGB, we must also remember that NHS Tayside are the employer of some staff, and my understanding is they have the responsibility in terms of professional and clinical responsibilities for those staff. So what I guess I'm saying is the lines are slightly blurred in terms of roles and responsibilities, and I can fully understand why we've ended up in this situation, albeit I think we're all noting that it's one that we wouldn't want to see happen again, and those lines of accountability and responsibility need to be clearer and indeed recognised and respected by all partners.
A very final point, Colin.
Thank you, Chair. I just wanted to, the last meeting of the NHS Tayside Board was just after, I think, the publication of the interim report from the independent inquiry, and I just wanted to reassure our public partners that I mentioned at the time. There was very limited discussion because the report had come out so shortly before the meeting, but I wanted to reassure the public partners that I mentioned at the NHS board at the time that there were a lot of themes identified in the interim report. My reflection was that those themes, if we engaged with and listened to and took more seriously the views of our public partners at an earlier stage, we would have identified those themes ourselves. I wanted to clarify one thing, just correct one thing that Councillor Purvis said. It was 2 years ago, I think this Friday, that the IJB authorised the consultation process for the mental health redesign. That was something that I did not at the time want to go ahead with the consultation on just one single option, but my recollection is that there were different answers depending on which section of the paper you read or which answers were given at the time at the meeting about whether there was more than one or only one safe clinical option. And the last point I think it's worth making is that the NHS board is happening tomorrow. There are a number of people around this table who will be present at the NHS board. We've got the vice chair, who's also the chair of the Care Governance Committee, is one of our members. I think that we will all have heard the concerns that the elected members and the public partners have raised today, and be communicating those back at the NHS board tomorrow.
Thanks, Colin. Gordon, I wonder if you could conclude your update, the ministerial group and the self-evaluation that we've got here.
Thanks very much, Robert. So what I have provided IJB members with is a copy of the self-evaluation that Perth and Kinross Health and Social Care Partnership submitted to the Scottish Government on schedule at the end, I think, of May, in relation to the Ministerial Strategic Group's review of the progress of integration. Now, this review, which was overseen by the MSG and its leadership group, considered the pace of integration and considered some of the themes that had come out of the Audit Scotland report that had been published a few months earlier. What you have before you is the self-evaluation that we carried out within Perth and Kinross Health and Social Care Partnership, and which was contributed to by colleagues in Perth and Kinross Council. The response from NHS Tayside to each of the 3 IJB's self-evaluations came later, and we have yet to incorporate it into the version that you see before you. Again, this is an item that will be considered tomorrow at the NHS board. In terms of the content of the self-evaluation, I would draw members' attention to the fact that what we've done is developed the self-evaluation on the basis of the work that we had done to populate the self-evaluation for the inspection. That means that we have looked very keenly at the progress that we've made and the current state of affairs in relation to any and all of the particular headings that are covered in the report, which members will see relate to collaborative leadership, integrated finances, strategic planning, governance and engagement. We have identified, as is requested, the particular evaluations relating to the indicators that are outlined in the MSG, many of which we've found to be partly established rather than established, or certainly rather than exemplary. Councillor Purvis helpfully reminded me that what I need to convey to you is the fact that in relation to the MSG self-evaluation, in relation to the inspection findings when we get them, and in relation to transforming governance and outstanding audit reports, we will provide the IJB with a consolidated improvement plan that talks about what are we going to do in relation to improving the progress that we made in relation to integration, in relation to engagement, in relation to strategic planning, the various aspects of this. I'm happy to take any questions in relation to the specific self-evaluation and its contents.
Thank you, Gordon. Are there any questions or comments? Eric?
Thank you, Chair. Yeah, in relation to one of the items in the report, the proposal 2.6, IJB must be empowered to use the totality of resources at their disposal to better meet the needs of their local populations, and that's described as partly established, which is quite right. And you see in this section and elsewhere in the report that the finances of the IJB are aligned rather than integrated, and that, I think that's a very accurate description. Fundamental to the integration, the full integration going forward, is the underpinning of the financial risk sharing arrangements, and I just wondered if I can have an update, please, on where we are with negotiations towards a different risk sharing agreement.
I'm going to let Karen answer this one.
Yeah, Karen, can you help with that? Has there been any update?
No, there is no update. The advice from my head of legal services suggests that the risk sharing agreement is indeed appropriate.
Sorry, just to clarify, was the risk sharing agreement not a 3-year specific one, and it terminated at the end of 3 years unless a new one was signed?
So the head of legal services has looked at the document, Councillor McDade, and she believes that it's still valid.
Great, thank you.
I think the issue was, and perhaps that's the clarity that we were looking for, that the 3 years was, at that point there was an option to go to a split based on the share that each partner gave in terms of income, rather than the operational split that we have currently, and presumably that's suggesting that we're continuing with the income split.
I mean, obviously Karen's taken our advice, but obviously it needs to be something that's agreed, you know, with NHST side, and I think they are actively looking to get to a point as earlier on in this financial year as is possible to make sure there's agreement with both NHST side and Perth and Kinross Council.
I think the reason why I particularly, and I think the IJB in the past have made the point that we prefer to go to a split based on, sorry, I should have said still an operational split, to correct myself, to go to a split based on the income from the partner organisations, was because we often felt that, particularly going through the budget review group process, there was a situation whereby we were still looking at the budgets in silos of social care and of health, and I suppose in order to work out who's responsible for what, that's necessary under an operational split. But if we move to that split based on the share that each partner gives, then it might help to encourage a more integrated budget setting process.
Thanks for your update, Gordon. Nothing further? Okay, thank you. Could I suggest that we have a break for 15 minutes, so we reconvene at 10 to 4? Thanks very much, everyone. Could I move us on to item 9.1? We have an update report from the Alcohol and Drug Partnership from Claire Mailer, but this afternoon we have Colin, who's going to... Would you like to speak to the report, Colin? Highlight any particular points? Obviously, people have Diane and Colin. Diane, do you want to introduce the report?
Happy to. Yes, apologies from Claire Mailer, who is the chair of the EDP, and Laura Kerr as well, who's our Teesside EDP coordinator, but Colin Payton works very closely with Laura. So this report highlights the progress made over the last year for the Alcohol and Drug Partnership. The National Strategy Rights, Respect and Recovery was published in December last year, and this was welcomed as it reflected the work that the ADP has been undertaking over the past 2 years, which has focused on prevention and early intervention, developing the recovery-orientated system of care, also embedding GIRFIC through the work of the partnership, and a public health approach to justice. We know that those with problematic alcohol or drug use are more likely to have experienced childhood adverse events, mental health problems, or domestic abuse as a few factors. Our preventative approach is very much underpinned by a partnership approach. As a result, we have reviewed our membership of that ADP and taken a broader perspective. Early identification is critical, so we need to move to improve access to information and access to effective treatment. We want to continue and develop the schools programme, support community groups, youth groups, etc., to think about how they support individuals in recovery. The stigma associated with alcohol and drug use is a barrier to early support, and a priority is to ensure that children, young people, adults and families can speak to someone who can help them. The second priority, to further develop a recovery-orientated care system, will support this approach. Ensuring that people have effective person-centred care is essential, and this is supported by effective treatment to reduce the use of and harm of alcohol and drug use. The recovery pipeline, which is in your appendix in Perth and Kinross, highlights the support available to individuals, which is a broad range of services to accommodate the very different interventions for each individual. We recognise the importance of access to support when somebody feels ready. In addition to the introduction of the multi-agency clinic, colleagues in primary care are also developing new ways of working. We have invested further in the peer-led approach, which continues to develop, and this includes peer advocacy posts being implemented. Getting it right for children, young people and families has been a priority for the ADP for several years, focusing on developing a whole family approach with close working between partners. Families should be recognised in their own right to ensure they are safe, healthy and supported. And this has been underpinned by getting our priorities right training across the workforce. In designing new models of support and working with individuals, families and communities, we strive to deliver high quality standards of support. The work of the Alcohol and Drug Partnership is underpinned by the quality principles and health and social care standards, and Colin can certainly talk about that as he's involved in the national improvement work. Collecting information and measuring performance is a key priority for the ADP to support service delivery, and the report highlights the work that's been done to improve this. Having good information and performance will support improvement and planning for drug and alcohol services both locally and nationally. The report details the work that has been undertaken to progress this. Do you have any questions?
Thank you, Diane. Are there any comments or questions that anyone has with regard to the update on the ADP work? Eric?
Yeah, thanks, and thanks, Diane, for the report. There seems to be a lot of activity around early intervention in this area, and I'm encouraged by the information on drop-in clinics, etc. I'm just wondering, though, to what extent the partnership is involved in efforts to address the prevention aspect, which is referenced in the report. I do see that, but in terms of, for example, the prevention of people developing an alcohol-related habit or illnesses, is there any involvement of this partnership in efforts to reduce the availability of supply of alcohol, especially to youngsters? And I just wondered if there's any specific local activity happening in that regard, and whether we have an early view on the impact of alcohol pricing legislation.
So I can address the question on looking at the younger population there, definitely with regards to research and evidence would say that younger people actually are drinking less than what they have in the past, and that is definitely coming down. One through education, definitely within Perth and Kinross, there is a good schools programme that has been worked on. I think that's not just as important, I think it's just as important for the young people and the children as it is for the adults that are part of that school programme as well, because I think that awareness raises that help to keep that going, that education and that talk, because I think one of the things that hasn't been done before, which in the schools has now been happening, is more around it's definitely around that awareness of what the effects can have, and as young people are starting to look more at their well-being, and I think using words like well-being rather than saying no is a big difference there. Looking what that does to your health and your well-being is a much more important route into that. I think also that conversation around where we're just have in the past said and I know what I'm saying, no to take and drink or drugs, but I think again having that conversation around why the reasons why someone feels that is okay, or the reasons why they're wanting to do that. We've talked a lot there in the past about the effects that alcohol has on young people through the trauma, but they're maybe hiding away using substances. So again, I think having those conversations early is definitely having an impact on them, reducing the use of their alcohol. Again, over the course of probably a couple of years now, and working with our colleagues within community safety and partnership within there as well, looking at where alcohol has been bought and starting to target more around that, and starting to have conversations with shop owners around the selling of alcohol and just what that means in doing that again, I think has had a big impact as well. In relation to, are you talking about, sorry, just to clarify that question, in relation to where alcohol is purchased, or the means of how many places are selling alcohol? Is that what you were referring to in your second part of the question there?
Not really. I note from the figures that there seems to be, comparatively speaking, a lot of pubs in Perth and Kinross compared to other parts of the country, and also that the incidence of alcohol-related problems is directly related to the proximity of access to alcohol. But my question was more around whether the Scottish Government initiative around alcohol pricing, whether you're seeing locally that is having an effect on.
Just to clarify, yeah. So again, I would say that just in relation to the alcohol pricing and the changes within that, and changes within the Scottish Government making, that definitely has had a major impact within regards to that. Being fair in answering that question as well, whereas people may have at times went to the pub and used that socially, I've got to say that as well, but now possibly within drinking as well, drinking at home, we've got to be aware of that as well. And I think these conversations are even coming here today is an exciting opportunity to have those conversations, because I think as we look at that, people maybe not going out so much anymore, but people drinking in the house, we need to address that side of things. But with the pricing and the change within pricing, then that is maybe not as what it used to be. Definitely is something to consider.
Thank you for that. And if I may, a further and separate question in relation to the drugs use aspect. Obviously, there are people who are addicted, and sadly, that's a problem of today's society. Again, I'm just keen to understand what, if anything, has been done within Perth and Kinross in relation to the possibility going forward of introducing drug consumption rooms, and whether there's a view on whether that would be an effective means of dealing with that issue in certain circumstances.
I think drug consumption rooms is a major topic and a discussion to have as we go forward. I think one of the things that we have to be realistic about and real about is how do we collectively challenge and help people to look at their substance use. And if consumption rooms was a means of doing that, then that might be a more safe way, a more protective way of doing that. But again, I think through very good education of people who use substances, I think starting to be a lot more a lot more joined up, and a lot more of our thinking is that we used to be quite a separate entity with regards to health, and with regards to our social work, in regards to our harm reduction, but now coming together and working more closely together. I think although there's not the consumption rooms, I definitely think that harm reduction message, that message of where people are working together and trying to tackle the root cause, because the substance is one bit, but that underlying trauma that somebody is facing, or the underlying pain, or the underlying whatever, is we can have as many consumption rooms, but until we start to work and we work more effectively and understanding the difficulty that someone's going through, then I think there is not an argument not to have a consumption room. But I think we are here within Perth and Kinross. We are moving forward. We are moving forward collectively together, and addressing that with our move to Drumheart Health Centre, and bringing the drug and alcohol team within the council, and with our TSMS within NHS, and our harm reduction service, and our third sector colleagues working collectively within that hub together, and looking to then duplicate that within the locality areas as well. I think we're starting to move more in that direction of trying to address the issues and difficulty in each one of those areas, and opening the doors for people to feel comfortable to come in. Because one of the other issues that I would just like to say, in addressing that as well, is you can create a consumption room, but it still depends whether somebody wants to come through that door to actually use that consumption room or not. What we need to do is ensure that the door is open there, and the people who work in there are professional and have the understanding, and have the right rights and dignity and respect and the standards that they need to actually work in that profession, so people come through and they feel they're getting the best response and the best service, not only from the drug and alcohol services, but I think as well, as we move forward, looking at the GP services, and also our point of contact services, and any other services that where someone can walk in through that door and need to address that conversation, like our alcohol brief interventions that were mentioned in the paper as well. There is a point and an opportunity to have those conversations, so we can build as many of these drug consumption rooms, but unless somebody walks through the door, it's not going to make any difference. We need to try and address that by opening up the conversations wherever that person comes in through, and start to be more real in having that topic of conversation with that person.
Thanks. Yeah, I mean, as a councillor for Perth City Centre, sadly, I'm aware of occasions, many occasions where there are people spaced out, consuming drugs in closes and back alleyways, and disused car parks and all the rest of it. And surely there must be, it must be a step in the right direction to, as you say, you need to encourage them to not to be there, but to be in a safer surroundings if they are going to take substances.
Thanks, Chair. So taking the discussion a step on from when people are sort of prepared to step through the door, when they're prepared to step through the door and they're looking for rehabilitation or recovery services, I've been through the paper. We talk about a drop-in clinic, which is available on a Monday morning, but it does say that the clinic is to support ease of access to ensure that an individual receives the right support at the right time. If it's only available on Monday mornings, then it might be slightly time limited. But we're talking about a model. We're talking about a pipeline. I would have been more interested in detail about a recovery-oriented system of. Sorry, I'm just talking about substance misuse rather than alcohol. So drug use rather than alcohol. I would have been more interested in the detail of the recovery-oriented system of care, how we're actually shifting people from use to intervention to recovery, and taking them eventually off drugs. All that the recovery pipeline shows me is a list of organisations that are involved. It does not in itself seem to be a system of care, and I wondered what the recovery-oriented system of care is.
Okay, so the image that you have in your pack, the pretty image that you have in your pack, actually has been worked on to. So we have a working diagram, just very much on what you're talking about there, and it talks about the different tiers of how people are working, and also where people with substance use come in, and looking at that journey that we talk about. We talk about everybody as an individual journey when they go through that, and how we can. I think the recognition is as well, just to say that how when somebody comes in, they may come in through the door of a GP, and what is that conversation that they first have there before even coming into a substance use service, from that substance use service. And you're right in what you're saying there about a Monday morning, but if we can start to at least try that and get somebody through the door there and start to address what that person wants in their recovery, because it is about their recovery, and then taking them along that journey within substance use services, and actually working with communities and working with other agencies out within communities to start to actually help to move somebody on from the substance use service back into community. One of the things I would say that we have been, and I would say that I'll use myself, that we've been guilty of in substance use services in the past, is we tended to hold on to people. We weren't as good at actually using what community services were out there to actually help somebody move through from substance use services back into the community. We've still got some work to do on that, but I think in regards to someone's journey, and what we're hearing now in evidence from people who are using services, is they feel that that door is open there now. There's better conversations, and then that path that they would like to take is what we work on now with someone. So we're talking about that peer educator, I think that's mentioned there as well, and peer workers as well, helping somebody move from that part that is often very difficult about completion, about actually coming off substances or reducing to the degree where they feel comfortable enough to move back into their community. Once somebody's back in the community, there's still an awful lot of work to do there. But again, one of the reasons we often held on to people was because of relapse, unfortunately. That is. But if we can start to work with people in communities and other projects within there that have an understanding of relapse, then rather than somebody coming right back into our services, that we work with people in the community as well. And we think we've got to get better at understanding that. So as much as there is part of a programme, be that methadone as part of that recovery programme, and working with somebody who is on methadone to either reduce it and to come off it, that is a timely process, and that journey is a long process, but it's very much about that individual's journey and that individual, where they want to live and how they want to live their life. And that ROSC is actually starting to form very, very well with a number of partners and our outside agencies having a better understanding, not just of drug and alcohol, but more of your well-being again and your mental health. And I think that is really important as we move forward.
Okay, and given, I mean, I think that there are, you know, there's a tax-paying public out there who would like to see maybe more, you know, direct interventions rather than, you know, to achieve the sort of end goal of recovery and rehabilitation, and not leaving people endlessly on a journey. But I understand clinically what you're talking about and the necessity. I'm just wondering whether you have any outcomes that you're aiming to achieve. So in terms of, you know, we've got a statistic quoted about the number of, was it hospitalisations in Perth and Kinross per 100,000 or whatever it was. Is, you know, are there outcomes that you're, in terms of numbers of interventions for recovery, for rehabilitation, minus any relapses, in terms of moving people back into, you know, positive destinations within the community, seeing their well-being off methadone, for example? What are those target numbers, and where do we monitor progress against those?
So I'd like to be able to give numbers, and unfortunately I can't just here at this moment in time. One of the things I think we've got, and I think it is in your paper there that was written by my colleague, was that we are now looking at a better performance measurement tool to start to very much address just what you're saying there, because we've seen that ourselves within substance use services. That whole bit about somebody moving back into the community and then sustaining their journey and moving forward, we haven't been, again, I would criticise myself in that we haven't been as good at doing that. So we are now looking at a better performance measurement and making sure that we can start to measure that. answering your question about outcomes, yeah, we want to see a reduction obviously in drug deaths. We want to see non-fatal overdoses being a priority. We want to see, one of the big ones for us is the return of people within a 6-month period. They are things that we can monitor, and we have monitored for a while, that we don't want to see people coming back through the door again. But at the same time, if somebody coming back through the door, it means then they feel safe in being able to come back through the door to have that conversation and move on. So there is as I say, a framework that is getting developed at the moment, and I'm sure unfortunately, had Laura been here, she would have been able to explain that better. It has been piloted within Angus and has started to work very well. We just need to now bring that here, and we're in the process of doing that, which will start to answer some of those questions, which will help us as well in developing that recovery pipeline as well, and how we can start to move people on and move people out of there as well.
And do we have an indication of when that framework would be in place? And maybe then get a report back aligned to that timeline.
Yes, and the report highlights the information that we're gathering through ISD and through the data sets. So we now have a sharing agreement. Well, hopefully you'll endorse the sharing agreement that we have in place, and we'll begin to collect that data. Sorry. In terms of I think that would probably be I would need to confirm that with Laura in terms of developing the framework, but certainly within the next 6 to 9 months we should be able to come back with a report.
Very much. I thought it was an excellent report, by the way, and I particularly enjoyed reading the ABI questionnaire, as it were. I didn't dare do it myself, I have to confess, but just a number of points was, and maybe you partly covered that in terms of benchmarking with Angus and Dundee City in terms of performance. It would be useful to see how we perform against those other bodies and what they are doing, what we're learning from their practice of what's good and what isn't so good. So that would be quite helpful. It's also just worth pointing out that this figure is highly, you notice public health was a major issue here. It needs to be on that agenda quite strongly. And just to say is that there will be a key consideration within our new strategy that public health is developing with the new NHS Tayside Public Health Committee that will be heading that up to give some focus to this work. So there's a lot of potentially good partnership working with you on that. So just to highlight that. I'm also particularly pleased that you mentioned partnership working with some of the blue light services and others, because there's a broader community safety agenda here, where they're often much more in tune with local authority and police and others in terms of the way they share data with each other. And I think that actually helps to often identify problem areas as well as problem people. So that's worth thinking about. And the other one is, there's reference to Perth Prison. Now, I'm conscious that the Perth Prison population from other reporting is likely to go up by another 100 over a given period of time. That will have some implications for the work that you're doing, and particularly the issue around about short-term sentences as well, because the ABIs may be less effective when you've got very short-term prison population. I don't know if you have any comment to make on that, but it would be useful to hear what you think about that, because I think there's a bigger public issue here for us.
I think the short-term prison population is a population, again, that we have worked closely with the prison, but so one of the initiatives that are going on just now, and we've just started, is actually some staff members are actually now within the prison working to actually build relationships with people before coming back out of the prison, because one of the things we had found is often when somebody came out of the prison, we lost them again for that period of time because the relationship wasn't there. So a lot of this is about relationship building. So we have in the last, I think it's only been in the last 4 months, we have had, working alongside the prison, we have had people going in there to start to build that relationship up. So when somebody does come out, they know on a Monday or whenever our other locality hubs are up and running, that there is a place to go to start that, continue that relationship on there, and also just to sort of shorten that time that often someone was waiting for treatment as well, so we can start that process before coming out. So we're just getting a lot tighter and a lot better at starting to address some of these issues that have been raised as well, recognising as well that often someone coming out of prison, that high risk, we would class that as a high risk area for someone then potentially, if they were to go back and use again, just due to their tolerance and stuff like that as well, that they may then have a non-fatal overdose. So again, just recognising that and where we can have those conversations and where we can have that relationship and where we can build that trust, it makes a big difference to somebody coming out of prison and starting to address their substance use and start their journey. But we recognise that the prison is part of that journey.
We have had additional funding from Scottish Government that also is supporting work within the prison, so in terms of dealing with the increasing population.
Just one other thing, there was research came out the other day there about increase in suicide rate in Scotland, and I wondered if there any correlation between suicide rate and some of the areas that you're dealing with. I notice it's not contained per se within your report, but I would have thought it must be a contributory factor to such figures. I just wondered if you had any data on that.
I haven't got any. I do apologise. I haven't got any data. I mean, again, I think if that was something I definitely would take that back to Laura as we look at the further report. But I do. Again, I'll go back to and addressing that and looking at that whole trauma that somebody has, that and how that their childhood may have been affected by that. Also, the means of why they're using the substance and what that brings on, and being able to manage that, and also that whole part there about addressing that. If we talk about substance use, I like that term now when we talk about well-being and trying to cover it under some banner together, because I think talking like that and actually working more collectively together is a more healthy way of starting to take this forward, rather than looking at substance use and looking at prevention of suicide. We've got to work together, and we are, and doing that as we move forward as well.
I would suggest that public health are absolutely critical to that in terms of both drug death and also suicide groups. So, and I'm sure we'll be able to pull that together.
Yeah.
Basically, I'd just like to say thanks to Bob for reiterating that, because the Public Health Committee, I think, will be looking, in terms of public health reform, substance use is key there amongst sort of the 6 key priorities, which I think the Public Health Committee and all of us want to try and translate into local action. So absolutely, substance use is there as a major factor. And I think nationally and locally, the profile of those issues is only going to get bigger.
Okay, thanks very much. I wonder if I could move us on, but before I do that, the recommendations were asked to note progress, also to provide endorsement of the DAISY information system and direct host organisations to implement a robust performance management system. We're happy to approve those recommendations. Are we able to direct the host organisations, encourage the host organisations to develop a performance management system?
Perhaps the language is request rather than direct.
Thank you for that clarification. Also, if I could just note, in terms of learning from other areas, at the moment I'm the chair of the Dundee, the Independent Drugs Commission in Dundee. We've provided our draft report to the Dundee Partnership. It will be launched publicly in the middle of August, and within that report there are clearly recommendations for the Dundee Partnership, but also recommendations that would be relevant across Tayside, but also within our report we've provided national considerations which we would ask the Scottish Government and Westminster Government to look at. But particularly learning across Tayside, I think our look in the past year at the situation in Dundee is relevant. Some aspects of that for Perth and Kinross and also Angus. Can I move us on then? Thanks very much, Colin and Diane. Can I move us on to 9.2? Diane, again, it's progress report on the development of the joint carer strategy.
Thank you. I'm conscious that the board had a presentation earlier this year relating to carers and how we were progressing. So this report is really setting out where we are in terms of developing our strategy, which is required by the Carers Act. In Perth and Kinross, we've agreed that the carer strategy will be all ages. So we're working very closely with our colleagues in Children Education Services, as well as the third sector, undertaking an extensive engagement programme to develop the strategy. There has been consultation for the the strategy, and we're now identified key priorities which we'll be able to bring back to the board in line with the strategic plan in September.
Thanks, Diane. Are there any comments or questions with regard to the update? Okay, thank you. Happy to note that. Thank you. And sorry, just in relation to that, sorry, I'll just come back to the recommendations. It's noting the report, but also directing. We have a direction within the report for Perth and Kinross Council and NHS Tayside in terms of helping to complete the care strategy. Okay. We're okay to direct at this point, Karen? Yes, I know it is a formal direction. So, okay. So you have no option. Can I move us on to item 9.3 then, which is progress by the Carers Programme Board and the implementation of the Carers Act? Diane.
Thank you. This report highlights the key activity in supporting the implementation of the Carers Act. The Carers Act is a major welfare reform piece of legislation along with significant carers benefits, welfare benefits, changes to welfare benefits. Initiatives such as short breaks have allowed carers to have time away from their caring roles, supporting their health and well-being and resilience. The Act is legislation which has set out key foundations to ensure that carers are supported in their caring role, their health and well-being is maintained, and that they can live their life alongside caring. We have identified 3 priorities in line with the national strategy, and that's to maintain carers' health and financial well-being, promoting carers' rights and listening to carers. It's absolutely essential that we work with carers and that carers' voices are heard and their views and experiences are taken into account. Locally, we have begun to develop that and are building strong partnership with carers. That includes Carers Voice, the Young Carers Service, and local carers are now part of our strategy group and our programme board. Supporting the carers implementation, the duties are outlined in 2.2 of the report. In Perth and Kinross, we've agreed the eligibility criteria, and that's been approved by both the IGB and Lifelong Learning Committee for young carers. We've also implemented carer support plans, waiving of charges, and improved access for carers within a hospital setting. And as outlined earlier, we're developing the carer strategy. The report highlights the investment from Scottish Government, which has allowed us to focus on new initiatives, as well as continue ongoing services, and that has included the telephone service, additional carer support workers. We recognise that there are still challenges in rural areas in particular, and this is a priority for the programme board to develop. This will be further explored through engagement activity with carers and also through the development of the market facilitation plan following the completion of the strategic plan. An audit report was presented to Audit and Performance Committee, and it was deemed that the arrangements in place are supporting the implementation of the Act. I'm happy to take any questions in relation to the progress of the implementation of the Act.
Thanks very much, Diane. Are there any questions, Bernie?
It's just a comment actually in relation to the adult support plans. I know that at the moment, I'm obviously part of the Carers Programme Board, we're looking at 10 to 12 weeks for people to be assessed as to have their carer support plan. It seems quite a long time. I know that it can be done through PCAVs and yourselves, but I don't know how that can be looked at to enable other people. It just seems that 12 weeks is quite a long time if you can't access your short breaks, etc., or various services unless you've got an adult support plan in place.
Yes, we've absolutely, Bernie. We have agreed that we need to review that, and in terms of our prioritisation, where carers do have critical need, in terms of the threshold, we would absolutely respond in a timely manner, and it's up to 12 weeks as opposed to having to wait for 12 weeks, but we recognise that we need to improve on that.
Any further comments or questions, Callum?
Just a couple. Can I ask, when I was looking through the eligibility criteria and where it talks about if self-directed support is agreed to meet the needs of the carer would then choose from the 4 options. I was just trying to think of an example of when, if you could give one of when it would not be appropriate for someone to, when someone would be deemed not to self-directed support would not meet the needs of the carer.
And it depends. If the social care support is not required through a self-directed support option, and it can be delivered in another way, that may be an alternative. So if there's a community group that we've worked with the carers, we've identified support for the carer within the local community that doesn't require social care delivery, then that would be an example.
So it's more when people would not be getting it at all in terms of
Well, getting alternatives to support to actual specific social care support.
Right. Okay. I just wanted to ask as well about the respite vouchers. Remember we had a discussion, I think, about this in the past about whether or not in some areas that have been struggling to use them with cooperatives and other means. Has that now been resolved?
We are working with the care cooperative in particular, and absolutely as part of our market facilitation plan and looking at how we commission services under option 2, then yes, we are looking at that. It hasn't been resolved fully in rural areas, as we identified that as an ongoing issue in terms of identifying appropriate support in rural areas, but it is absolutely part of our commissioning strategy.
And just further on to that, obviously we have in Highland Perthshire, as we've spoken about before, quite a widespread and robust network in terms of the cooperative model there already, and there has been in some areas where either they've been supporting or Growbiz is supporting, and I know that you've been engaging with people. I think this small project in Kinross, one in other parts of Western Perthshire. How are we in terms of, I know I've spoken before about, is there a way in which we can facilitate the setting up or encourage the setting up of this on a more widespread basis, whether that's through the expansion of the cooperative model, the cooperative that's already there for Highland Perthshire, or whether it's setting up ones for different localities in parts of Perth and Kinross?
It's ongoing work for our community engagement workers, which we've continued to invest in terms of that work alongside other community capacity building activity. We are in conversation with the care cooperative in terms of their model, in terms of how we can support other communities and other entrepreneurs to take that forward. So it is something that is a key for each of the engagement workers within Perth and Kinross.
Sorry, it's just to come back on Councillor Purvis's point with regard to the respite vouchers. I attended the meeting last week with regards to that, so it hasn't been resolved, but we certainly are looking at that. And really it was for clarification with regard to SDS. It was my understanding that if a carer under the adult support plan comes under the criteria for low or moderate, that they would not necessarily become entitled to SDS, that it's only if they are assessed as under high or very high. Is that not correct?
Self-directed support is the vehicle to deliver social care. So social care can be delivered by a whole range of different support organisations. In terms of social care that's provided by the Health and Social Care Partnership, then those thresholds have been agreed by the IGB. If we recognise that there is a need to invest to support that carer, then absolutely we will look at that if it's below the threshold. However, ordinarily, as agreed by the IGB, we would work within that threshold as part of the eligibility framework.
Correct.
For specific social care. However, there's a whole range of support that carers can receive. Absolutely. Yeah.
Absolutely. I'm not disputing that at all, but for the criteria to enable them to have a payment under SDS with regards to the eligibility criteria for the council to support that, it would be under high or very high. Under low or moderate, they could be referred to our third sector organisations for support, which would not come under SDS.
Absolutely, that was what was approved by the IGB, yes.
Thanks very much. Can I take you to the recommendations? We're asked to note progress in implementing the Carers Act, also to approve the direction to Perth and Kinross Council as set out in the second bullet point, and also to approve the direction to NHS Tayside in the third bullet point. Are you happy to approve those recommendations? Yes, thank you. That takes us on to the Primary Care Programme Board update. We have a report on prescribing and an update. We obviously have had a discussion earlier on in our meeting today around prescribing, the budget for prescribing. I don't know, Hamish, if you would like to highlight key aspects of the report.
I think most of the areas that I was wishing to highlight have been covered already in the report earlier. I can go through it if you like, but I'm happy just to take questions on the report.
Are there any questions in addition to what we've heard earlier today or this afternoon with regard to prescribing? Anyone would like to ask, comment on? Colin?
Yeah, thanks, Chair. The commentary between tables 8 and 9 talks about a substantial price increase for a small number of drugs. Notably losartan, which increased in price in the order of 700%, increasing our expenditure from £4,000 to £27,000 a month. Reasons given for this include, I'm not quite sure why stockpiling would lead to a price increase, but production issues as a consequence of batch contamination. Why does the customer pay for manufacturing issues?
I think it's a supply and demand issue, I think, along with the hoarding of drugs or the stockpiling of it for a possible Brexit issue. I'm afraid these things, I can give some probably fairly uneducated comment on it, but the reasons behind it are complex and completely out with our control. We don't set the prices, we don't negotiate the prices, so they are what they are, unfortunately.
Okay, thank you. And you have gone into, before that, there's the talk about the Strathmore GP cluster being an outlier in terms of the prescribing, and you've gone into some of the details there. I was wondering if you could just explain a wee bit more about what engagement you've had with the GP cluster.
So the practice, this is the first time we've presented this sort of information. So far in the past we've concentrated on providing individual practices with variants and for them to look and for them to discuss with our programme leads and our lead prescribing GP and pharmacist about what they can do to make an impact, having it be identified. We've heard from my colleague Dr. Alistair Noble in the past about locality allocation and cluster allocation of resource, and I think this was one of our attempts to look and give clusters the information to then have a peer-to-peer conversation across practices within the clusters about, well, why is my practice different from the next practice? And there may be very good reason for that, but it will, as I say, this is the first time we've produced this sort of data. We now intend to provide it to the clusters, to the practice, to have a discussion, to come back and say, well, okay, let's look at this in a bit more detail, or this is the reasons for it.
Thank you.
Through the whole meeting, but thank you very much for your update report this afternoon. It takes us to an item for information. The 11.1 is the Qualities Outcome Progress Report for noting, for information. Right? And our future IJB meetings, whilst we have the two dates that are set, the 27th of September and the 11th of December, we will contact you as soon as possible with regard to a meeting at the end, probably the end of next month, but we'll confirm the date for a special meeting to look at mental health service issues. Thank you very much, everyone, this afternoon for your contributions to this meeting.